side effects are still problems and worries. So the country is not that rich, and the individuals might not be able to afford the cost of transplant. And the complications resulting from the transplant procedures are also what makes people to be a bit afraid. The cost of investment in transplant surgeries are very high. And so people really want to get reassurance that when they go for this procedure, they will get a cure. Those are the challenges.
So very nice. I think that sets the ball rolling. There's just not the transplant is either delayed. The cost factor is smaller the baby, smaller the cost, lesser the cost. Earlier the age group, earlier better the outcomes. So I'll show you some interesting data which has just been published 6 months back, talking at what age should we get the best transplant outcomes. If you have to say today I get pregnant, at what stage should I get a bone marrow transplant is needs to know. Second biggest problem in sickle cell in my country is the delayed diagnosis, that every pain crisis in India is considered as malingering. People really don't know whether they think the baby does not want to go to the school, and that's why they're complaining abdominal pain. So there's so much of a research which needs to be gone into sickle cell, and it is just not the SS levels. You might have a 40% SS, 50%, 60% SS levels, and you might just be asymptomatic. So the thing is, it's a very, very heterogeneous disorder. Sickle cell being a very heterogeneous disorder, it is very, very important to understand the signs and symptoms very, very carefully. That's the most important thing I think we need to do.
Yes,
so people have started asking questions. So let's start. Yeah, please, Dr. Emmanuel, you were saying something. So we'll start. I am Dr. Rahul Bhargav. I am Dr. Rahul, Director at Fortis Memorial Research Institute in India. Over to Ms. Toyan.
Yes, I'm Toyin Adeshola, the Executive Director of Sickle Cell Advocacy and Management Initiative. I'm also a warrior, sickle cell warrior, living with it for over 5 decades, and I'm a sickle cell advocate.
Dr. Emmanuel.
Okay, thank you very much. I'm Dr. Emmanuel Sani. I'm a hematologist, a consultant, honorary consultant hematology in Nizami Hospital in Abuja, and a lecturer in hematology in Nile University of Nigeria, with specific interest in sickle cell, hemato-oncology, and stem cell transplantation. So, very welcome to this meeting.
Over to Dr. Tahir.
Yes, my name is Dr. Lawal Musa Tahir. I'm a consultant pediatrician with Nizamiya Hospital, Nigeria.
Dr. Tahir, you have to have more adrenaline rush.
Sorry?
You have to come close to the mic and have adrenaline rush. You can speak loudly.
Okay. Can you hear me now?
Very nice.
Okay. My name is Dr. Lawal Musa Tahir.
We can hear your melodious voice.
Okay. My name is Dr. Lawal Musa Tahir. I'm a consultant pediatrician with Nizamiya Hospital, Nigeria. I'm into neonatology, but with special interest in sickle cell disease.
Very nice. So let's start the discussion. So coming back to Ms. Toyin, what do you see in today's world? What is your wish list? You have got 3 doctors sitting with you. What is your wish list?
Well, my first wish list is I hope that I would like for better understanding on how managing the pain of people with we are pretending that we have pain. We don't understand the level of pain we go through. So that would be my wish list. And then to understand that one of them is people with sickle cell can't take iron tablets. I've seen situations where people come to me and the doctor give them iron tablets to take. So I think basically get more educated on how to manage sickle cell, and finally get a cure that is affordable for all. Unfortunately, the low income people are the ones that have the numbers of people with sickle cell. So doing something in the millions or even hundreds of thousands will not get to the downline of people with sickle cell.
So, Dr. Emmanuel, as Dr. Ms. Toyin has said, that her wish list is to get a cure. But before cure, what is the medication you're looking at to help your patients?
Currently, we for our own settings in Sub-Saharan Africa, where we have the largest population of sickle cell in Africa and the world, we are much concerned about sickle cells. And we have them a lot, and we are worried about presentations and complications. My take is that the emphasis should be on the pediatrician who handles these patients in the early stage, pediatric hematologist, because by the time you get to adult hematology, so many complications are set in. And most time we're not comfortable when we see them with complications at the adult stage. So what we need majorly is awareness, even among the pediatricians, on the use of the common drugs that is available with us. Currently, we use adosuria a lot for our sickle cell patients, and we want to encourage our pediatricians not to be afraid of the use of adosuria. Once there is indications for the use of adosuria and sickle cell, they should commence them early so that we can know those that will be ready or will have indication for bone marrow transplant before the age of 16. Because we know very well that the earlier we do bone marrow transplant for those that have the indication, the better for us. When they get to adult stage, and we have seen them with avascular necrosis of the femur, we have seen them with stroke, we have seen them with impairment, cognitive impairment, we're worried, and we know the risk that happens with bone marrow transplant after the age of 16 years. So we want our pediatrician to be conversant with the use of adosuria. The dosage regimens, they must be familiar with it. Sometimes they just place patients on a fixed dose without revealing the dose. We know very well that when they commence them on adosuria, they were supposed to follow up the initial dose of 50 mg per kg, and 4 to 8 weeks, we expect a follow-up of 5 mg per kg, up to a maximum of 30 to 35 mg per kg, or to look at the minimum tolerable dosage. Those pattern has not been well followed. So I'm worried about that, because when they come to my clinic, I commence them on adosuria, but sometimes some of them have suffered morbidity. That reduce the lifespan, that make a lot of worries. Currently, the drug we use is adosuria. That's our mainstay. Then of recent, we have introduced Edavit for those in crisis, and it has really helped them. Those two drugs have actually been Epinos with the other therapy in management. Pain management has been a challenge for patients with adosuria in our environment. Most times they will need to be on opioids. Those are our challenges. That's what we've been using so far.
You have summarized it well, that along with the awareness, you require the correct diagnosis, correct dosing of the medication, and early referral to the hematologist. Dr. Tahir, what is your opinion? Why is there a level of awareness when people are getting born? Have you seen in past 10 years that people have started and acknowledging sickle cell more comfortably than it was in previous decade?
Actually, there has been a tremendous improvement in the level of awareness as well as early diagnosis in the last 2 decades. Let me give you an example in the northern Nigeria. Recently, people have begun to accept and adopt a way of presenting your genotype certificate before a marriage is contracted, which I can tell you 2 decades ago, if anybody tells you that we will go this far, you will have a lot of doubt. Probably this is because awareness has significantly improved and the diagnosis at early age has seriously improved. In those days, people used to think that probably sickle cell disease is one mysterious disease and they hardly think it's even a disease that needs to be treated in the hospital. But this has significantly improved. Dr. Sani talked about hydroxyurea. Again, in the last 2 decades, there has been an improvement in the wide use of hydroxyurea because earlier
So,
on
Dr.
people
Tahir,
were
before you come to hydroxyurea, how commonly in your practice, and Dr. Emmanuel, I'll come and bring you in here, how commonly you use transcranial Doppler and a chronic transfusion therapy in your clinical practice? And Ms. Toin, I have seen many of the African, not African, I would say Ugandan sicklers developing a stroke at the age of 3 months, 3 years, and leading a very bad quality of life. So all three, I'm more interested in knowing that do you do transcranial Doppler velocities and do you put them patient on chronic transfusion therapies?
Because for our center, we
not about the transcranial Doppler study in a lot of hospitals, but though these are hospitals in bigger cities like in Abuja, it's actually a protocol. We have to do at least a baseline cranial Doppler study, and every 6 months to 1 year, depending on the finding. Chronic transfusion for especially those that have had stroke is widely used in Nigeria.
Okay, so Dr. Emmanuel.
Dr. Sani, can go ahead, please.
Yes, the transcranial Doppler transplant is a routine aspect of treatment plan for patients with sickle cell disease in Nigeria. Although most facilities do not have that, and that is a challenge. But we've been able to advocate the use of transcranial Doppler transplant to detect early risk for stroke. And for the patient that I've seen so far that have suffered for stroke, as for my own practice, they've been chronic blood transfusions together with the use of I will need partial exchange transfusions, and they've done very well, pretty well. In fact, the response without even almost seeing no mortality, morbidity sequelae from the stroke. I have noticed that we did 2 or 3 stage partial exchange transfusions, and they have survived. But most cases that I do are adult patients. My emphasis is more on the pediatric patient before they come to us. I have my patients that have suffered stroke in pediatric age group before they come to adult clinic, and I'm not happy when I see those complications. So I felt free use of transcranial ultrasound to screen those that will be eligible for hydroxyurea treatment as well as chronic transfusions. And also bone marrow transplantation early in life so that we can reduce the mortality. Thank you.
Ms. Toin?
Okay. For me, we always educate people about our parents about taking their child to do Doppler tests. We have the Sickle Cell Foundation here in Lagos does, and we encourage them. But what I found out is that a lot of times when they are put on, after the confirmation that they are high risk, when they are put on drugs, the ability to maintain those drugs to treat or prevent stroke is the challenge, especially when they come from a poor family background.
Absolutely.
And then for EBT, exchange blood transfusion, we do it here. There's a manual type they do in Luth, but we found that there are challenges with that. We found issues of 2 of our patients going unconscious because they couldn't exchange on time. And then we have the one that they use machine, but it's very expensive, anything for 250K, and how many families can afford that? And the fact that you have to do it maybe every 3 months, every 4 months, just to be able to do that, it's challenging. I have been through exchange blood transfusion. I know how expensive is it. I had to go on HMO to be able to qualify, and cut costs for myself. So it is a challenge in terms of cost.
And moreover, Dr. Emmanuel and Dr. Tahir will agree with me that the hydroxyurea actually does not reduces the risk for a stroke. Even after a chronic transfusion, you put the patient back onto hydroxyurea, it does not reduces the risk of stroke. So I'll show you some data to suggest which how and we need to do it, and then we'll come back.
Dr. Bhargav.
Yeah.
So before you explain the data, I have a question actually. I have met a lot of people from all over Africa. And I remember, as far as I can remember, the first time I met Miss Toin, everyone is so confused about this drug hydroxyurea. I'm always getting this question, when to use hydroxyurea, what is the perfect age to start hydroxyurea, till
So I'll
what
just show
age
it to
should
you.
we take hydroxyurea, are we abusing hydroxyurea? So please explain to the viewers, like, what is the right age to start and what should we do?
Okay, so it depends upon which continent you believe in. If you believe in Europe, then you will wait for 2 years. If you believe in America, you will start from 9 months of age. In fact, the red cell transfusion and hydroxyurea, they are the only two things. So transcranial Doppler velocity needs to be done. Cardiac diseases can be prevented by giving hydroxyurea. This is the screening modality for sickle cell. This is glutamine, new methodology which has come by. We can discuss twice a day, sachet 15 grams, which needs to be given. There's another drug called voxelotor, which has come, which is soon approved in Ghana right now. This can be utilized to prevent the patient from getting sickle cell crisis. Fetal hemoglobin induction has been utilized very well. This Novartis drug is soon going to be available. Crisanalunib will be available to prevent the pain crisis. Rivipansel, another one which prevents the adhesion for sickle cell. So these, you see, these are the newer medications which are available. Glutamine is available, voxelotor is available, IMR 687 is available, crisanalunib is available now from Novartis, and Rivipansel is in phase 2 trial. Now, hydroxyurea. The only thing which we need to remember this is hydroxyurea has to be given from 9 months of age. So don't wait. If the transcranial velocity is high, put the patient on chronic transfusion and they become subject for bone marrow transplant. Greatest benefit is shown when the maximum tolerated dose, which is to maintain absolute count less than neutrophil count between 1.5 to 3. Start with 15 mg per kg body weight, increase the dose to 5 milligram per kg per day every 4 to 8 weeks until the maximum dose is achieved by monitoring the absolute neutrophil count or 30 to 35 milligram per kg body weight. So remember, it is every single sickle cell. Please try to put the patient on hydroxyurea by 9 months of age. This is what we do in India. The reason is it prevents sickle cell crisis, it prevents infection, it prevents osteonecrosis of the joints. This is very, very important. And believe me, the side effects, apart from infertility, and that too not permanent, there is no incidence of cancer has been found out. So these are the new drugs and new hopes for sickle cell patient which we have. The cheapest is hydroxyurea, second cheapest is glutamine. Glutamine can also be utilized to reduce the pain crisis. But what hydroxyurea does not do, does not prevent silent infarcts. What it does not do, does not prevent stroke. That we need to remember. So best age for transplantation is 12 years, less than 12 years. Remember the word less than 12 years is the best chance for a transplant. Conditioning is myeloablative. Type of donor, sibling. So we have got two types of transplants, either from brother or sister or from the mother father, what is called as half match transplant. Indications, primary stroke prevention. People who have got higher transcranial Doppler velocity or people who have developed stroke, they should be subjected to either sibling transplant or a half match transplant. One thing which you need to remember, not every person will get a sibling transplant because siblings will not be there. or even there's a sibling, it will not be an HLA match. So if there's no HLA match, there's a specific indications for doing half match transplant. Prevention of cerebral infarcts by chronic transfusion. If there's a silent cerebral infarct, those patients do not get half match transplant, but if they have a sibling transplant, they do get. And these are the recommendations for transplant, which is called match sibling transplant. Baseline hemoglobin 7, splenic sequestration, stroke, abnormal transcranial Doppler stenosis, infarct, recurrent VOS and ACS, osteonecrosis, priapism, and so on and so forth. So if you have the very, very simple algorithms, you can remember that. In a cerebral vasculopathy, if you have a stroke with the cerebral arteriopathy, chronic transfusion, and you have a match, please go ahead and do the matching with an HLA. So any person who has got a high transcranial Doppler velocity, who's in chronic transfusion, needs to get an HLA typing done. That is very, very important to know, that they need to get a HLA typing done. But if there's a silent infarct in the absence of stenosis, they will only get a sibling transplant, not the half match transplant. Similarly, for the veno-occlusive crisis, which are controlled by hydroxyurea, good enough. If not getting controlled, please proceed ahead and get the match sibling transplant done. That is very, very important. And people who do not on hydroxyurea also, on hydroxyurea itself, if the people are not able to control their pain, they can proceed ahead for the transplant. So what we have learned in this setting is that bone marrow transplant will be required for a severe patients. So if we have now, we can come back to the discussions. Those people who have got severe disease, as Dr. Toin has said, as Dr. Emmanuel has said, that people who have got increased transcranial Doppler velocity, they have developed strokes, they should proceed ahead and get a sibling transplant done. So there are two types of transplants, sibling and half match. And that's why I'm trying to bring it out. Dr. Emmanuel, do you think that every sickle cell patient will require a half match transplant?
No.
Hello?
No, I don't agree with that.
Perfect. So please explain to the listeners. Please explain to the listeners that if I say every person requires a transplant, the next question comes to their mind is, I don't have a brother and sister, then how will I get a transplant? So can you tell, does everybody requires half match transplant? Dr. Emmanuel. Okay, Dr. Dr. Tahir, what is your opinion for a transplant?
Well, for those that need transplant, they should have a transplant. Because if you don't do it in time, even if you decide to do it later, the outcome may not be favorable. So the earlier it is done, the better. Because the better outcome, and you minimize the damage that could occur from not doing it.
So Dr. Emmanuel, how do you see this 12-year data which has come now in 2019 in Lancet, that people who are about 12 years of age or 13 years of age, their chances of success starts coming down. It is not zero, but the best age to do a transplant is less than 12 years. What do you have to say about this? Ms. Toin, you have to unmute yourself.
Questions about transplant.
Yeah.
Yes. So for me, I am worried about that because most of my patients are teenagers and adults. They are worried about their chances when they do transplants. And for me, too, I'm also worried about what is their take. By the time you have the transplant in older patients, we know that the risk of graft-versus-host disease is increased, and the ability to have a success rate are also lowered. For me, before the age of 12 years is very good. So if the pediatricians can do and do a good follow-up for patients with sickle cell, they can do the transcranial Doppler ultrasound early, know the eligible patients bone marrow transplant early in life, even the money of fund to be able to do transplant. So they will save a lot of our patients from the complications. So for me, the advocacy still need more to go for to the pediatric hematologists to do more in terms of their screening for eligibility for sickles for bone marrow transplant, and they will really help us in that regard. For me, I want them to go for transplant early for those that are eligible, because I know that the cost of transplant is so high, and you know Africa is poor and the resources are not there, so nobody wants to waste money on transplant. Find out that there were complications, to find out the screening processes and to put them together early. I'm also advocating for a situation whereby we can have a group where we can look for eligible patients so that they can do it in numbers. Instead of one patient, two patients, we can actually look for screening for everybody, maybe in Abuja, do a screening process for them, look at those ones that are eligible and try to convince them, reduce the cost of the transplant for them and match them for transplant. It will really help a lot and save adult hematology clinic from the complications. And looking forward for that, advocacy for sickle cell patients in Abuja to start with, do a free or even possible close to a free transparent Doppler ultrasound and screen those that are eligible. Some patient relatives are willing and they are ready, but you need to convince them that their money is not going to be wasted and there is going to be safety from the procedure. Thank you.
Ms. Toing, what is your concept of bone marrow transplant? Do you think that these people who are sicklers, who are severe sicklers requiring blood transfusion, do you think that they should be subjected for transplant? And what is your wish list for a country like India and others? And how much should be the cost need to be brought down for getting the successful transplant done?
Yeah, I think for people who have potential to have stroke, it's a very good idea to put them on to carry out BMT on them. What, as Dr. Emmanuel has said, is awareness. People are worried of the chances of whether you take it. Because like, let's face it, it's like any basic transplants. Some can work out, some cannot. So I think there needs to be more education in terms of that. And the cost is so important, because yes, I like the idea of bringing people in multitude so that to lower cost. But even then, how much will it be lowered? And it's only a particular set of people that will still be able to afford it. And then one thing about BMT, because I know a couple of people who have done it. I think there's, apart from getting them to do the bone marrow transplant, there should also be psychological and physical education and therapy regarding bone marrow transplant, because I've seen people who have even battled with the issue or post BMT. So I think it has to have an all-encompassing strategy in helping people to be able to understand whether they need bone marrow transplants or not.
Absolutely right. I think the most important thing for all of us is to understand is the grading the severity. Until unless we don't grade the severity of the disease, we will never come to know who requires what. The first Dr. Emmanuel has said is that what we need to do is understand the severity of the disease. And once we know the severity of the disease, then we can proceed ahead and get the transplant done. One. According to the severity, then we have to use hydroxyurea in all the patients. And once we start utilizing hydroxyurea with an appropriate dosing, going up to 30 to 35 milligram per kg body weight from 9 months of age, I think that is going to ameliorate more symptoms for these patients. And the third thing is the understanding of newer drugs which are soon going to be available in the market, understanding their evidences and utilizing it. And fourth, not the least, is the bone marrow transplant, which needs to be done early rather than at later stage. So what I would suggest that every person below 12 years of age, they should get an HLA typing done. At least that's not very expensive. And if they have a disease which is very severe, then they should be subjected either for a matched sibling transplant or a half matched transplant. That is very important for all of us to understand. half-match transplant has got limited indications, while match sibling transplant, which can be easily done with a 92% success rate in the worldwide scenario, we need to go ahead and do it. As we know, the newer medications which are doing for bone marrow transplant, they are becoming better and better. So I think that's the way we should proceed ahead in today's world. The rest about the awareness, I think Dr. Emmanuel, you need to have more presence on the social media in your local language. Ms. Toin, you need to have a on Twitter, on Facebook. You people have to have a massive awareness campaigns for people to understand sickle cell disease. Please tell me.
Yeah, I think awareness is very important. We have to go out there, but like in all things, when you're trying to create awareness, you first of all have to understand the challenges yourself. Giving out information that you're not too sure about is another thing. So I think meetings like this help us get a better understanding of bone marrow transplants and the steps that you need to take. I know in America, even when you want to do BMT or stem cell therapy, they ask you first if you are on hydroxyurea, how long you have been on it, and it's only when they find that, okay, despite the fact you've been on it, it hasn't really worked for you, they now recommend, okay, you should go for such transplant. So I think the education, the having forums like this with fellow medical people to be able to get a better understanding of these things is very important.
So Dr. Emmanuel, what is your thought process regarding gene therapy?
The gene therapy is just coming up, and it offers a lot of hope for a lot of people, though there have been research work on it and trials. For me, I like the gene therapy because of the graft-versus-host effects associated with bone marrow transplant. It's not there. For gene therapy, by the time it comes out more, I think more patients will be interested. In fact, at least I have over 4 patients that have told me they're waiting for the outcome of the gene therapy for those trials that was done and presented last year in British Journal of Hematology. For me, I like the idea of the gene therapy because it reduces the effect of the use of drugs and the complications are reduced more. The issue of graft-versus-host disease is also lower, and the issue of post-transplant medications are also going to be tolerable compared to bone marrow transplant. So for me, I am actually an advocate of gene therapy for most cases of sickle cell anemia patients. For me, I felt the cause might still be our problems. Though by the time it comes out, the cause may really be a challenge to us. But we are waiting. So Africans, I know some groups in Africa that are also be interested in trying to see whether they can join the research work. But I know that in Paris, in France and Spain, there are a lot of work that being done on the issue of gene therapy. We are hoping this year, maybe by the December, we have to have outcome until COVID-19 came up again and disrupted a lot of work. So for me, I would like to hear from you whether you have any information how far gene therapy has gone in India, because my patients are interested in that.
I think Dr. Emmanuel and Dr. Tahir, what do you think? Is gene therapy going to replace bone marrow transplant in the future?
It may because I'm not expecting gene therapy is going to be cheaper than bone marrow transplant. And you can see we are all echoing the fact that even the bone marrow transplant is expensive for a lot of our patients. If you look at the disease burden in Africa and Nigeria, and unfortunately, a lot of people cannot afford the care. Even you can remember Ms. Toyin talked about people not being able to afford hydroxyurea. So having gene therapy is going to be a very good, welcome idea, but it may not replace bone marrow therapy sooner.
Very nice. So I think the most important thing we need to understand. Hello?
Yeah, before we move ahead, I want to ask this one question always keeps up popping. People want to know, like, does every sickle cell anemic patient, do they need a transplant?
No. So not every single sickle cell requires a transplant. That's what I said. understand the severity of the disease. If you don't have any pain crisis, or your pain crisis are being managed by hydroxyurea, you don't require transplant. The absolute indication will be people who have a stroke, who require chronic blood transfusion, who has got osteonecrosis, who has got priapism, who has got more than 3 to 4 crises requiring hospitalization. So severity in sickle cell, it cannot be like thalassemia where everybody requires a transplant. In sickle cell, it has to be individualized and it has to be picked up early. That's the key discussion which we need to have with our counterparts across the world, is understand the severity of the disease. And that is what makes a difference. And that's where the awareness comes, as Dr. Emmanuel has said, that making people aware about the severity. One, there are two challenges. One is to make them understand about sickle cell. And second, the major thing is how they need to understand the severity to get the best treatment.
Thank you, Dr. Rahul.
So at this point, what I would suggest to you is, Dr. Emmanuel, I'm so sorry, Nishan, there's some pressing need which has come up. You just continue your discussion. I'll just join you back in 5 minutes. Is that okay?
Of course, not a problem.
Sure. So for a bone marrow transplant, length of stay is for 3 months in the country. The procedure in India costs $20,000 for a matched sibling transplant. Sibling, please start getting the HLA typing done. The most important thing, Dr. Emmanuel and Ms. Toin and Dr. Tahir, is that we need to start doing HLA typing. So somebody has asked to do a particular test on hydroxyurea. When I bought the result, nothing was said afterwards. It meant only for children. So there's a chat section. You can keep on answering the questions, please. I'm 34. Can I still do BMT? Mrs. Sarah, the important thing is, are you severe enough? If your disease is severe enough, then probably yes. Otherwise, just continue on hydroxyurea. And hydroxyurea patient has to get, every 15 days, they have to get the CBC test done. Complete blood count to see what is my neutrophil count. We need to see our complete blood count to see and check for neutrophil count. Dr. Emmanuel, what is your suggestion?
That is what they must do. That's what we do in our environment too, because we know that neutropenia is one of the side effects of hydroxyurea use. We know that myelosuppression is also there. So the complete blood count helps in monitoring, and it helps at least to be able to assure the patient that they are okay. For me, that is what we do in Zamia Hospital, the Turkish hospital. We do the complete blood counts to be able to monitor them and to be sure that they don't continue drugs where there is neutropenia. For most of what the patients that we have seen, will not be able to have significant neutropenia to warrant drug stoppage. But my appeal is still to the pediatrician to continue to monitor the dose to the maximum level so that you can have a maximum benefit. Thank you.
All right. Thank you, Dr. Sani. So I guess Dr. Bhargav had to leave for some reason. He might be back in 5 to 10 minutes. So I would let you guys discuss on the same topic. Ma'am Toin.
Yes.
Yes.
Okay. That's the topic of hydroxyurea, right?
Right.
Or which topic are we discussing?
Yes, we can talk about that hydroxyurea use.
Okay. Yeah, I'm on hydroxyurea. I started. I first started like 20 years ago, but not much was known about it. So it was erratic on how I was given, how I was monitored. But I think I started about almost 2 years now because I kept having repeated blood transfusion. My PCV kept dropping down after each blood transfusion. So that's how I was on it. But there's a lot of, like, I think it was Dr. Emmanuel, you were talking about how there needs to be education about it, because I find that when doctors you tell them, educate them, or like put them on hydroxyurea. There's no follow-up. There's no every 3 months monitoring. Like he said, blood tests. They don't do it. They don't tell them, okay, when that is based on their weight, and they should review that it's based on their weight. I remember when I was first, I'm very small and petite, so they gave me a large dose, like 1 gram. I reacted. That's how they now checked my weight and changed it to the normal, the right dosage. And since then, I've been on that dose, because anything higher than that, I notice there are issues. So I think we need to educate people when doctors are giving them, they need to educate them that, look, you need to do regular follow-up on your hydroxyurea, check your check your liver function, your kidneys, and all the other tests that you're supposed to do, because people just, take hydroxyurea. And I know some people who started even on social media, I'm using hydroxyurea, come and collect it from me. And, they just give it out as if it's a normal drug, whereas it has to be monitored.
Well, like Ms. Stein said, there is serious need for awareness. There seems to be very poor awareness about this drug itself. There is undue fear, and that fear, it has to do with the issue of carcinogenicity, which, thank God, that issue is being under plate now, since Dr. Rao told us that they have not had one case of cancer from hydroxyurea. So what we actually require is this advocacy, this awareness. As the burdensome as sickle cell disease is, if we are able to give people. Hello? Hello?
Yeah, can you hear me?
Yeah, I can.
Yeah.
Hello? Yeah.
Yeah, I can hear you. Please tell me.
I can hear you.
So we are talking about the use of hydroxyurea. One of the problems that actually led to people running away from hydroxyurea was the issue of the carcinogenicity that was linked to it. Thank God that from what Dr. Rao told us, that they have not had a single case of cancer from it. And this is reassuring. So there is need to actually go out there, make public campaigns, so that even the prescribers will have their mind at rest that this carcinogenicity is more of a theory than in real life. And that could probably help in prescription and a wide use of this drug that could help mitigate the effects of this disease. Thank you.
So I think the most important thing for all of us to understand is basically to make people compliant with the therapy. Until unless those people don't get compliant, they will not get benefit out of it.
Sure.
And people are asking, should we be afraid of hydroxyurea? There has to be a national campaign saying that people should not be afraid of hydroxyurea. They need to be given. They need to understand, because hydroxyurea tends to work very well, and those are the ones which can save your life as well. So I think
can I say something about that? Yeah, a national campaign is good, but I also think there should be more awareness among pediatricians, general practitioners on the use of hydroxyurea. I think that's why some people are scared, because I've seen the effect of the misuse or the way that doctors gave the dosage, and they've seen things happening. So that's why they have this perception that it's a general issue. So I think, as well as awareness for the public or those people living with sickle cell and their families on using the drug, I think there should also be more awareness among medical practitioners.
I think absolutely right. Ms. Toin has raised a very valid point in saying that the correct dosage of hydroxyurea needs also be told to people. And that's the very important thing to understand also. So I think it's a very well taken point. With all these points which are coming up, I think we need to consolidate it, saying people need to be aware, people need to start doing HLA typings, and they need to start understanding about bone marrow transplant along with the therapy. Not everybody will require therapy, not everybody will require bone marrow transplant, but yes, those people who are severe and sick, they do require bone marrow transplant. And Ms. Toyin has actually put it very right that these are the people we need to be seeing too often than not, and making people aware about various therapies which are going to be soon available in the country. So Ms. Toyin, as a final remark, what would you like to tell people, that can they win over sickle cell? Should they be afraid of or not?
No, don't be afraid of sickle cell. I think you just have to understand your body. Like I said, I've been living with it for 55 years, and I've begun to know what triggers it. And there are medicines available that can help support it. I know sometimes we do get tired of taking all those drugs on a regular basis, but I tell people, look at somebody who has diabetes. I'd rather take a drug than an injection every day. And sickle cell is not only the health challenge that is around there, other worse challenges that are around. And I think it's just how to manage it and understand what you should do and what needs to be done. And if you're interested in hydroxyl, go for the pre-test. It's very important. Do the pre-test to know that you're okay, your functions are okay, your blood tests are okay. And once you're put on it, please make sure, even if your hematologist does not remind you about doing the regular 3 months test or 4 months test to check your blood, do it yourself and take the results to them for them to review, because it's very, very important. We shouldn't just be popping the drug. And then another thing I notice is that people pop it, like I say, pain medicine. When they have pain, they just take it for maybe a month, drop it. You cannot afford to do that. In fact, sometimes your crisis gets worse when you do things like that. So you have to consistently take it every day as prescribed. And if you're interested in BMT, with those indices, potential to stroke, AVN, and then, as I said, early, do it early. I see people doing it older age and saying, oh, it didn't work really for me, or I still have issues. And those are the challenges that we see. And then you have to still take more drugs. So it's very important that we do it early and seek the right people to give you advice on that. Yeah.
Very well said, Madam Toyin. I would like to ask a question out of curiosity. What I have seen in Nigeria is people, like, they prescribe the drug hydroxyurea themselves. If I am suffering from sickle cell anemia and I meet a friend who is in crisis, I'll just go, okay, you can just pop these pills. This is gonna help. So Dr.
That's what
Emmanuel,
yeah.
yes, right. Yes.
That's
So
what I said earlier on, and that's what I see. People say, somebody said on social media, oh yes, there's this drug. They were talking on Twitter.
They're promoting
there's
it
this
like,
drug. I have
yeah,
some.
they're promoting
Come
it
and
like
take it.
some pain pill or something.
Yes. So
Yes.
that's why I said there needs to be a lot of awareness, because you're making things worse for yourself. The person you're giving it to may not be okay taking hydroxyl. You don't know, and you're making the person's health issues. Even in my group on we always tell people, don't recommend drugs, because what may work for you may not work for another person. One man's meat is another man's poison. So it's very important that we don't self-medicate. Seek the right people when you're taking any drugs. It's very, very important.
So what do you think, Dr. Emmanuel, is the right way? If I am suffering from sickle cell anemia, this is my first time that I got to know about that I am a sickle cell anemic patient. So should I go to a hematologist? Should I listen to my friend who is suffering from sickle cell anemia? He's in popping hydroxyurea drugs. What shall I do? What is the right way to find it out?
For patients with diagnosed sickle cell anemia, the right thing is to get to the hospital and request for the service of hematologist.
Right.
Oftentimes, the internal medicine physician used to click on the patient with sickle cell anemia. Unfortunately, they didn't know much about the disease, and they get most of them into more complications because they hold on to patients. I've seen a lot of internal medicine physicians, rheumatologists holding on to sickle cell patients instead of allowing hematologists to see the patient in facilities where we have hematologists. Those are still problems within the healthcare facilities. Seeing rheumatologists interested in sickle cell patients, holding on to sickle cell patients when it was supposed to release sickle cell patients to hematologists for treatment. They complicate matters and they get matters worsened. You can imagine sickle cell patient with chest pain crisis can develop a patient that have vaso-occlusive crisis with chest pain, can develop acute chest syndrome. And if they develop, they now call hematologists to come in when complications are setting. They want you to do the magic there. Those are problems within the health cycles I have seen them do. They don't have enough information about the sickle cell patient and they will not release the patient. That is within the health facility, that's the problem. So patients should request for the service of the hematologist, and hematologists know how to handle them and collaborate with the pediatric hematologists to make sure that the complications are minimal and they start them on treatment early. The aspect I'm more interested in is that the pediatric hematologists should monitor the dosage of the treatment and they should evaluate them further and do the required investigations so that we know those are transplant and so that they can reduce the severity of this disease and we can
Yeah, can I
So
add
Dr.
something to that?
Yes, sure.
Ms. Toin and Dr. Emmanuel and Dr. Tahir, I would like to take a leave. I have to go somewhere. My apologies for that.
Thank you very much.
Thank you very much.
Good night. Thank you.
Yeah. We will continue with this.
Thank you, Dr.
Thank
Bhargav,
you
for
very
being
much.
with us.
Bye. Okay, yeah, I was going to, yes, I agree with you about people holding on. I had a situation where a hospital held on to a sickle cell patient until the thing really got worse is when they now started saying, okay, we'll transfer to a specialist. And unfortunately, before they could transfer, the person gave up the ghost. And another thing I find out is that I don't know whether Dr. Emmanuel and Dr. Tahir, there's limited number of hematologists in this country. They are not readily available, let's face it. And there's some private hospitals who don't even have any hematologists at all. And I know a few who are even overworked because everybody is just coming to them. So how can we as medical practitioners encourage more people to go into hematology as a specialty? Because we need you guys. That's a serious truth.
Everyone, let's welcome Dr. Vikas Dua.
Hello.
Dr. Vikas.
Hi, Nishan. How are you?
Yeah, I'm good. Dr. Vikas is a pediatric hematologist, director and head of department in pediatric hemato-oncology in Fortis Memorial Research Institute here in Gurgaon. So he's a pediatric doctor. And doctor, here we have Dr. Tahir with us, Madam Toin, and Dr. Emmanuel.
Hi, how are you? How are you, everybody?
Welcome, Dr. Vikas.
Welcome,
Thank
Dr.
you.
Vikas.
Thank you.
How are you?
So I'll pose my questions to Dr. Lawan and Dr. Emmanuel on the hematology issue.
Apologies for joining late.
Yeah.
No problem. No problem. Like you said, interestingly, if we look at our discussion today, sickle cell, despite the burden of this disease, the takeaway from this discussion is that the key to fighting and mitigating the effect of sickle cell disease is appropriate information, early diagnosis, and institution of appropriate measures to handle it. In a situation where you have a few hematologists on ground, public advocacy is probably going to help in that aspect. And that's one of the things that I would like subsequently your organization is something this program. How do we go about this? And how do we minimize this effect of the shortage? Because it's not something you can produce over 2-3 days. It's something that takes time before you can produce the required number of hematologists you need in the system. Thank you.
Thank you, Dr. Tahir. Dr. Vikas.
Yeah, hi.
Hi. So we have a question that's popping up again and again. That is, there's a lady who is having issues with getting pregnant. She is
Mhm.
asking if the fertility issues using hydroxyurea are permanent or not. What do you suggest?
Okay, so we need to understand friends that hydroxyurea very, very rare can cause fertility issues. Very rarely. In my last 10 year of practice, I haven't seen anybody having hydroxyurea issues, but usually that doesn't happen. So tell the families, tell the people not to be worried. It's not very common. It's a very, very, maybe a very, very rare sort of thing.
All right, Dr. Vikas. Also, I would like you to educate our people, our audience here. Why is it
Mhm.
always better to do the transplant in an early age? Why a pediatric transplant is better than an adult transplant? What are the complications that one can get if they're doing an adult transplant?
Oh, that's a very fantastic and a very good question, Nishan. So all of us who are listening to this, they need to understand that as your child has got sickle cell anemia, as your age increases, there would be a more chance of having a complication which could be a temporary complication like pain crisis. It could be a permanent complication like a stroke happening to a child, and then the child would be bedridden or would be hemiplegic. So we need to understand that if we do a early transplant, once you detect somebody to be having sickle cell anemia, you subject that child to bone marrow transplant, you may achieve a phenomenal outcome which could be close to 95 to 98%. So when I say 95 to 98%, that means if I do 100 transplants for patients of sickle cell anemia who have got a full match donor, 95 to 98 would do well. Whereas if the age increases, let's say somebody has already got a stroke, has got a infarct, further from happening, but already has happened to you in the past would not get rectified. That's why we always say earlier the better. I hope I'm clear and people are understanding this.
Hello.
Yeah.
Yeah, there's a network problem, sir.
Okay. Yeah. Can you hear me?
Yes, we can hear you now. We don't see you though.
Oh, okay. I don't know what is the issue going on. Nishan, can you see me now? I can very well see you. I can see you.
Yeah, we can see you now, sir.
Yeah. So earlier is always better, because if somebody has got a complication because of sickle cell anemia, if somebody has got a stroke, is hemiplegic, so the transplant would not prevent something which has already happened. It can prevent further complications from happening. That's why earlier the better.
All right, so thank you very much. So, Dr. Sani, Dr. Tahir, and Madam Toin, are there any other questions that you would like to raise?
Yeah, I'm concerned about the question the participants are raising. I don't think we have addressed all of their questions. The questions from the participants, I don't think we have addressed them.
We are getting that, we are saving that, sir, but because we are short of time, so we would be answering those questions later on.
So Nishant, if we have any further questions, you can just blast me with this question and I can answer that.
So what I'm doing is I'm making a notes of the questions, and I will send it to you after we're done, and we'll mail it to the patients. So because there are a lot of them.
Mhm.
Okay. Yes, my take final one is not a question per se, it's just an advice for every individual. Couples getting married must make sure that they read their genotype, they do their hemoglobin concentrations and their levels. They must know their genotype before they get married so that they don't marry those individuals that are not compatible. The inheritance of a sickle B gene must not be inherited. The individual cannot come together and marry. If individual has a sickle B gene, he should make sure that he marries somebody that doesn't have the sickle gene. That is the best way to prevent the disease, which is the most important aspect and cost saving. The other aspect is a pre-implantation genetic diagnosis. which is just coming up, and the IVF fertility centers are taking advantage of this. For couples that are married, that the ASAs that are married, they can take advantage of this, though it's still costly, but they can use it to prevent the birth of sickle cell patients. For those that are living with sickle cell patients, it's not a death sentence, and quite a lot of my patients does very well. It's the disease has different severity. It could be very mild, it could be moderate, it could be severe. Some who have mild disease, far somebody doesn't have any symptoms or complication in the last 10 years. He has never been admitted, he has never had blood transfusion, and he's doing very well to the age of 40 years. So it's not a death sentence. So for those that have complication early, the pediatrician should help us in the screening process so that we can get them out for the treatment. And those that have failed in the treatment early in life, we should match them for HLA typing and bone marrow transplant. Then the hope that we have is gene therapy that is coming that will offer some help from numerous category of patients. The drugs are expensive. There's Brita in the market. I don't think any Nigerian patient can afford that. It's millions of dollars. We can't afford that. So we have foundation that can help Africa for that kind of drugs. I don't know whether the drug is cheap in India. Hello,
Dr. Vikas.
Yes,
I
yes.
don't
I'm
know
so
whether the
sorry.
drug is cheaper in India.
I think I lost the connection in between. What is your question, sir? Nishant, what is this question?
So Dr. Sani wants to ask if the drug is cheap in India.
Which one? Which drug? Which drug? Which drug are you asking?
Osivita.
Voxelotor.
So maybe
Are
we
you?
use the different names. What's the name,
So,
sir?
is it Voxelotor?
Yes.
Dr. Sana, I think maybe you should type the drug or something so that he can hear. I don't think he knows what drug.
Yeah. So can you just type that, or you can just is it? Are you talking about hydroxyurea, glutamine, Voxelotor? Which medicine are you talking about?
The third one, he said.
Oxybrita is Voxelotor.
Sorry?
Oxybrita.
Oxybrita, sir.
Oxybrita. All right. So Oxybrita is the name, is the commercial name for Voxelotor. Okay, I am understanding. So Oxybrita is a commercial name for the salt is Voxelotor. That's what I was saying. So Voxelotor is not available in India. It has been approved by FDA in USA. It was approved on 25th November 2019 by FDA to be used for patients of sickle cell anemia to decrease the hemolysis to increase the hemoglobin. So it is not available in India. Around 100,000 US dollars, 100,000 US dollars annually.
Yeah.
So it's a very expensive medicine, my friend, and it is not available in India, nor it is available in Africa. But it is a wonderful drug. I can tell you about this drug. This drug is to be taken orally. 1500 milligram once in a day is the recommended dose. And the recent trial, which was done over 274 patients, that was called the HOPE trial. In that, it showed that those patients who were taking 1500 milligram of Voxelotor had significant improvement in hemoglobin, significant drop in hemolysis. That means the bilirubin drop, and the common side effects which were observed by the use of this drug, which was seen in around 10% patients, were just headache, diarrhea, abdominal pain, nausea, some rash, fatigue, and pyrexia. So these are some of the rare side effects which happened. But it's otherwise a wonderful drug. But we need to understand it's very, very expensive.
All right. Okay.
Thank you, Dr. Vikas. So what I'll say is, because some of our speakers, they need to leave as they have other conferences. So I guess we should wrap it up. It was a wonderful conversation. It was very great to have you all together here on this platform. We couldn't answer some of the questions, but I'll make sure that we send them a particular reply.
Thank you very much. Thank you very much, Nishant, for bringing us all on a common platform and on the occasion of Sickle Cell Day. I think we should all pledge and make a pledge that we should make our countries sickle free forever. And those people who have already got sickle cell anemia, they should not be disheartened, because bone marrow transplant can change their lives. Thank you very much.
Thank you. Thank you, Dr. Vikas. And once again, I wish you all a very, very, very happy World Sickle Cell Day.
Thank
Thank
you.
you.
Bye-bye.
Thank you all.
Bye. See
Bye.
you.
Thank you,
Bye.
Mr. Queen. Thank you, Dr. Lawa.
Thank you.
Bye.
Thank you,
Thank
Dr.
you.
Sani. Thank you, Dr. Tahir.
Thank you.
Thank you,
Thank
madam.
Thank
you.
you,
Thank
Ishan.
you.
Thank you
Yeah.
very much.
Thank you.